Hello, everybody, and good afternoon. Thank you for joining us today. My name is Garrett Schmidt, and I am the managing editor for vvcexhibithall.com. And I'd like to welcome you all to today's live presentation by Stellar Health. And it is called The Teacher Becomes the Student, How to Successfully Implement Value-Based Strategies into Academic Medical Centers. This is a really interesting topic, and so I'm excited to hear what our speakers have to say today. I hope you are as well. A few items of note before we get started. Everyone's joined today in listen-only mode, so you don't need to worry about muting your mic or turning off your camera. We can't see you, so that's okay. But during the webinar, we do want to hear from you. So we are going to have a Q&A towards the end, but you don't have to wait until that time in order to ask your question. At any time during the presentation, you can ask a question using your attendee module. There's actually an area on there for questions specifically. It's different than the chat, so it's actually just for questions. So at any time during the presentation, even at the very end when we're wrapping up, you can ask your question even if we've run out of time, because any questions that come in that we don't have time for today, we're going to make sure to answer via email afterwards. So we definitely want to hear from you. And then finally, the webinar today is being recorded. So what's going to happen is after the presentation is done, I'm going to send everyone who has registered a link to the recording. And there's also an area there where you'll be able to download the slides. So that will come out probably a couple hours after we're done, but I will send that to each of you. And then, of course, if you have any feedback or if you have any suggestions or things that you want to hear about or anything we can do better, please let us know. We'd love to hear from you. Finally, without further ado, I want to introduce our speakers today. We have Dr. John Fitzgerald, who's got several amazing titles here that I'm going to read for you. Professor of Medicine Emeritus at Indiana University School of Medicine. He is also the former SVP for Population Health at Indiana University Health. He is the former president and CEO of Indiana University Faculty Practice Plan as well. So very happy to have you, Dr. Fitzgerald. And we also have Maria Reimholt, and she is the Director of Market and Strategy Development with Stellar Health. So I believe Maria is going to get us kicked off, so I'm going to hand it over to you at this time, Maria. Welcome.
Thank you, Garrett. Appreciate you having us today. Really looking forward to the discussion as value-based care continues to evolve. I think an understudied area is value-based care in academic medical centers, and we're very lucky to have the advisory of Dr. Fitzgerald, who has been there, done that, and been very successful in value-based care. So we'll be able to share today some of the lessons he's learned, and also as Stellar now works with academic medical centers across the country, we'll share some of our learnings today as well. Before we do that, we have a couple questions we want to pose to the audience to get to know you all a little bit better. Just two questions today to get us started. The first one, do you represent an academic medical center?
Okay, this is Garrett again. I put the question up, so it looks like a lot of you are submitting answers. We're going to wait just a couple more seconds for everyone to submit their answer. Looks like they're still coming in. And then we'll show the results. Okay, it looks like most of the answers have come in, so I'm going to go ahead and close out the poll here, and I will show the results. Maria, are you able to see that on your end?
I cannot, no.
Oh, okay, well, let me read them to you. So the question was, do you represent an academic medical center? Answer was yes, was 38%, no, 58%, and not sure was 5%.
Great, thank you. For those of you who are not sure, we'll help define that term a little bit more today. So hopefully by the end of this, you can more confidently answer that question. And for those of you who don't represent an academic medical center, I believe there will still be some fundamental takeaways on implementing value-based care that you'll be able to apply to your organization or any other organizations you may represent. Our next question is really targeting the 38% of you who do represent an academic medical center. We're curious to learn if your organization participates in value-based care.
Okay, so the answer or the question is up. If you guys want to submit your answers, we'll wait just for a minute while everyone does that. Okay, about 5 more seconds for all the answers to come in. It looks like most of you have responded, so I'm going to go ahead and close this out. And I'm going to share the results. Okay, so since our speakers can't see the answers here, the question again was, if you do represent an academic medical center, does your organization participate in value-based care? And answer one was yes, we're all in. That was 47% of you, so that's a high number. Second was we're dipping our toe in the water. That's 37%. So between those two, that's a high percentage of all of you. Third answer was we want to figure it out, and that's 16%. And then what is value-based care? That's 0%, and I'm glad that's 0% because this might be a little over your head if that's 0% for you. But it looks like we've got a lot of folks that are interested in going forth with value-based care. So I'm going to go ahead and take down the results now, and we can continue.
Great, thank you. Let me know when you can see my screen again.
Yeah, for some reason the polling questions kind of knock us out of the presentation mode, but we can see it now, so you're good to go.
Perfect. Well, as Garrett mentioned, I think we have the right audience here in terms of organizations who are committed to value-based care and/or are interested in getting more involved. And I'm sure all of us know that there are areas that we can improve performance in value-based care. And that's exactly what Dr. Fitzgerald will be sharing with us here now.
Well, thank you, Maria, and good afternoon, everybody. I wanted to share my experience and perspectives about value-based care in academic health centers or academic medical centers. That's been gained from my role as several roles, as Garrett had mentioned, the CEO of the Faculty Practice Plan and Executive Associate Dean for Clinical Affairs at Indiana University School of Medicine, as well as being the leader of IU Health's Population Health Division and the CEO of its ACO that contracted with Medicare and a couple of its value-based programs. I can't say that all of the specific tactics and strategies at IU are applicable to all other AMCs, since really if you've seen one academic medical center, you've seen one academic medical center. But I've tried to identify higher level principles that I feel are key to success in the value-based care at academic centers. The title says we're going to talk about value-based care strategies. So I guess the first task is to define what we mean by value-based care. It was encouraging that 0% asked what is value-based care. But I think if we asked 100 individuals, we might get 50 different answers. So for purposes of this discussion, we're going to refer to value-based care as what I'll call risk-based care. These are programs where the provider, and in this case, the academic medical center, takes on the risk for the total cost of care of the patient. Now, this risk can be either full or partial. And the services could be financed either by fee-for-service architecture or via a population-based payment or capitation. What we're not referring to are pay-for-performance programs in which the academic medical center can receive additional payments or fee schedule increases that are tied to achieving goals in quality, length of stay, readmissions, or mortality. Also, many academic medical centers participate in what I'll call condition-specific risk arrangements, such as joint replacements or oncology care or cardiovascular care, in which the expected cost of a condition is bundled into a single payment to the provider, regardless of the actual costs. For purposes of this talk, we are not referring to those types of programs either, although several of the discussed principles, impediments, and recommendations are going to be similar. Again, what we're talking about are programs in which the provider is accountable for the full spectrum of care, soup to nuts, to a population of individuals. These are programs such as Medicare Advantage plans, where the AMC is taking the risk, or ACO type contracts with Medicare, including the Medicare Shared Savings, the direct contracting entity, and the ACO REACH programs. We should also explain what we mean by academic medical centers. Again, for purposes of this discussion, it includes both what I'll call academic health centers and teaching hospitals or major teaching hospitals. Academic health centers are those large tertiary and quaternary care focused organizations closely linked to a medical school, if not part of the same organization, in which there is a large focus on extramurally funded research, as well as the training of medical students, residents, and fellows. The medical staff members of these organizations tend to be medical school faculty, and many of whom have priorities and a career focus that is not clinical care. For our discussion, AMC also includes major teaching hospitals. These are typically larger community or safety net hospitals that participate in the training of medical students and residents. They typically have the full spectrum of specialties. However, these organizations are not so tertiary and quaternary focused in its care, and will likely have a broader primary care base than an academic health center. They often lack the research focus of an AHC, and the medical staff members are more often full-time clinicians. So we'll begin to include both in referring to AMCs in today's discussion. And though each suffer from similar impediments to success in value-based care, I believe these impediments differ by degrees. Now, one of the main disadvantages of AMCs is their cost structure. We'll discuss this more fully later on, but a few stats cited by a study by Navigant. It's a little bit dated perhaps, but I think the concepts or the conclusions still hold. First, this study, Navigant found that the cost per case was 5% higher in AMCs compared to non-academic hospitals. And that translated into an annual additional cost for academic medical centers of about $3.1 million. But there were some positive signs. They found a 22% disparity between high and low performing AMCs. So some are clearly doing better than others and succeeding in lowering the cost of care. And then if you look at their performance in recent years on readmissions or hospital-acquired conditions and other value-based pay measures, they've improved, all of which will facilitate success in a risk-based, value-based care program. So, although we've learned a number of AMCs are deeply involved in value-based care, and presumably many are performing quite well. Let's work from the premise that many AMCs find it a challenge to participate and perform well in value-based care programs, where they have to assume the risk of the cost of the full continuum of care. I think those challenges can be attributed to several factors that involve issues with strategic alignment, the operating model within an AMC, the culture within an academic medical center, physician engagement, and lastly, financial issues. So let's examine some of those in a little more detail. In most AMCs, there are multiple stakeholders and a lack of strategic alignment and priorities among these stakeholders. By definition, AMCs typically have a tripartite or bipartite mission, which results in health system executives, deans, department chairs, program directors, physician leaders, all potentially having different priorities, some of which may conflict with the delivering of care that is of the highest value. Research or teaching may be the top priority of some of the clinicians participating or delivering care, and be an impediment to producing highly accessible continuity care that's of high quality and low cost. The traditional model of most academic medical centers, which I might add has served them very well in a volume-based care world, can also be an obstacle. Many are focused, as mentioned, providing tertiary and quaternary care. They attract patients from wide geographic areas across states, even internationally, for very high-end care. However, their delivery footprint, the actual delivery footprint of these organizations, and the mix of providers is not broad enough to attract and manage a population across the full spectrum of care. The care provided at academic medical centers, while at the highest level of expertise for a clinical problem, is often uncoordinated and fragmented, as the academic medical center often lacks a network of necessary providers to manage care across the full continuum. Also, the distribution of specialties within an academic medical center workforce is not adequate for effective value-based care. Typically, AMCs are very heavy with specialists and lighter on primary care physicians. This is especially true with the large academic health centers. However, it's this latter group, the primary care physicians, that is required to attract the volumes of patients necessary for actuarial stability, as well as necessary to provide the basic primary and preventive care, which is the cornerstone of successful value-based programs. I mentioned culture as an obstacle. Many of you listening will recognize that individuality is a trait that characterizes many physicians within an academic medical center. Team-based care across specialties is often an anomaly, and you can often find significant resistance to uniformity and standardization of care processes applied to clinical conditions. Again, I believe that's one of the important factors for success in value-based care. Physician engagement may be an issue. Research or teaching may be the top priority of some of the clinicians and result in a much less than full-time effort spent on clinical work for many providers. It's not uncommon to find a physician researcher with 10 or 20% of their time dedicated to patient care. Not the best for continuity and access. Key components of successful value-based care are continuity and access. Many providers will also have teaching responsibilities at the same time they're delivering care. This may detract from the time that's required to optimally manage and coordinate care. The physicians, the providers may also not have the tools to help them identify and close gaps in care and provide a more comprehensive and accurate approach to risk adjustment. Lastly, I think there are a number of financial issues that make value-based care a challenge for AMCs. As previously mentioned, AMCs have an unfavorable cost structure that makes it difficult to succeed in value-based care. Now, AMCs are very vital organizations in our healthcare industry. Things such as new discoveries of better or transformative treatments for many conditions, in cancer, cardiovascular disease, infectious disease, et cetera, originate in AMCs. New technology and surgical approaches often result from AMC developments. And the next generation of the physician workforce gets trained in these organizations. Yet the costs of providing tertiary, quaternary, high-end care, of training medical students, residents, and fellows, and of hosting or supporting cutting-edge research and discovery are really formidable. And these generally aren't borne by non-AMC organizations. So the playing field is not level when one looks at the cost structure and compare AMCs to non-AMCs. Additionally, many AMCs are very important safety net providers in our communities and provide care for a very disproportionate number of uninsured or underinsured individuals, again, putting greater strain on the finances of an academic medical center. These days, it seems that the value added expense associated with the AMC's missions of education, research, and high-end care is becoming harder to defend to insurers who are seeking the highest quality at the lowest cost. And to date, AMCs have been unable to unequivocally show that outcomes for routine care is any better at an AMC. Another key factor for performance success in value-based care is having significant longitudinal investment in infrastructure, I'll call. Infrastructure that includes both information systems and personnel. Adequate systems capable of producing actionable data and reports, as well as ancillary personnel such as care managers or social workers or clinical pharmacists, et cetera, are really key components to success. The ability to prospectively identify high-cost patients and then having the specialized personnel available to address their needs are really requirements. The longer an organization participates in value-based care, then the more proficient and effective it becomes. But it may require several years of significant investment, sometimes millions of dollars per year, before the costs are offset by savings. Lastly, physician compensation plans at AMCs often don't provide incentives for the behavior required to succeed in value-based care. Frequently, compensation is via a fixed salary for a year without any incentives for exceeding explicit, high-performing value-based care goals. There may be additional pay for productivity or high numbers of RVUs, but rarely is there compensation linked to quality, cost control, risk adjustment, or access. So as I mentioned, I've been with IU Health in Indiana University School of Medicine for a number of years. And it's an organization that has had some success in the value-based care world, though it's still a work in progress. IU Health is an academic system with an AHC, that is a tertiary and quaternary care hospitals for adult and children, and has 14 community hospitals, most of which host learners of some sort. It's closely aligned with the Indiana University School of Medicine, which is the largest allopathic medical school in the country and trains over 1,000 residents and fellows each year. IU Health owns a health plan that offers Medicare Advantage and commercial products, and in 2012 developed an ACO that contracted with Medicare in the shared savings program. A few years later, the ACO switched from MSSP to the next generation ACO program, and this year is participating in the professional DCE program. About 5 years ago, the system doubled down on value-based care and decided that it needed to become a top priority and made a full commitment to its success. You can see from the chart that the ACO's financial performance in the next generation program improved significantly. Additionally, during the last 2 to 3 years, the ACO achieved nearly 100% quality scores. And in the MA program during the same time frame, we lowered the medical loss ratio to about 88% from over 102%, and raised the star ratings of the health plan from 3 to 4.5. So what then were the lessons learned as we continue with our work in progress? So first, we had extraordinary support from the executive leadership, from the system, from the medical school, from the departments, from the physician groups. I think it was a realization that developing the ability to perform in risk contracts needed to be a core competency, as the tea leaves indicated that the future would require provider systems to take on risk. Until that point, we had tried to outsource or allow the health plan to not be very focused in its efforts to try and manage performance. The system gave a long-term support and commitment of investment in systems and infrastructure as we learned how to perform. And it required 6 or 7 years of learning and improvement until savings offset the investment in infrastructure. Leadership recognized that this was a marathon, not a sprint, and thus the need for long-term commitment for support. A second learning was the need for primary care. We had a fairly robust primary care network with over 350 primary care physicians who were employed. However, we additionally partnered and contracted with outside groups, some independent primary care groups, a primary care network, and a couple of federally qualified health centers to provide a greater mass of primary providers. This allowed us to attract a volume of patients, which on one hand brought more risk because of larger number of covered lives, but it also brought some actuarial stability to the program and made us less vulnerable to random events. We also learned to not try to boil the ocean. This took a little work, but eventually we learned that we needed to target the biggest opportunities and focused efforts on those opportunities until they were addressed and resolved. We engaged relevant specialists with our primary physicians to standardize care and standardize care processes, and selectively attacked certain chronic diseases such as heart failure, COPD, chronic kidney disease in the Medicare population, that attacked causes for readmission, that attacked the costs of post-acute care, that addressed risk adjustment, improving its accuracy and better preventive care. We concentrated on these high return targets and didn't move on until we were satisfied that these targeted areas were brought under control. It was a way to focus our efforts and our resources in those areas that offered the greatest return. Once we had designed our care processes and care pathways, it was extraordinarily important to provide practitioners with actionable data and reports that were available at the point of care. It was critical that as the physicians were encountering patients, that they have tools or they had reports that allowed them to improve quality, reduce costs, and increase risk adjustment accuracy, especially in the Medicare Advantage program with HCCs. I think lastly, another lesson learned was adopting a team-based approach was really important. High performance in this space really took a village. So we integrated select specialists in our primary care offices, either virtually or face-to-face. We involved the entire office staff in the primary care setting to help close gaps in care. And by adding in-office care managers, pharmacists, and social workers, that helped improve our performance by being part of the primary care team. An important association in this team-based approach too was assuring that all members had incentives for improved performance, either as part of provider compensation plan or via transactional payments for desired behavior, or incentives for the office staff to improve performance of their particular office. Primary physicians and specialists, to a lesser extent, had a significant component of their compensation based on hitting goals in quality, access, and risk adjustment. It drove substantial behavior. These incentives drove substantial behavior and improvement in performance. So, based on our experience at IU and my observation, I think there's a few core requirements for success in value-based programs for academic medical centers. I think first, absolutely, you must have a consensus and support of senior leadership that excellence in value-based care is a priority, and there's a willingness to invest for the long term in the necessary infrastructure to assist providers in performing. I think you need a strong foundation of engaged primary care providers. Now, many AMCs, especially academic health centers, don't have their own employed medical group that's large enough to really compete in this space. Thus, for a lot of AMCs, it's really important to partner with other primary care groups, perhaps a CIN, a clinically integrated network, or even other non-academic systems. I think it's critical to standardize and coordinate care across the continuum, not just the care that's in the hospital, and do it in a team-based model. This will require engaging both non-provider team members and specialists who might be relevant to the care processes. I think it's important to align financial incentives for the desired behavior that will promote success, behavior that will increase quality, improve access, and improve cost outcomes. Providers are economically rational beings. They're going to do what they're paid for. And then lastly, assure that the system infrastructure is designed to capture what I'll call appropriate and timely data that can provide actionable performance reports and nudges to physicians, to providers at the point of care. So you may ask, did IU Health, we're going to hear from Maria in a little bit, did IU Health engage Stellar for help and assistance? And no, we didn't. However, I left IU Health in my position in population health in the ACO a couple of years ago, and subsequent to that, I became acquainted with Stellar and some of their real leadership. And in conversations, I realized the similarities between the approach we deployed at IU and some of the principles and tactics we used were also used by Stellar when assisting other systems and other health plans in trying to improve their performance. So with that, I'm going to turn it over back to Maria for comments on how Stellar might help AMCs meet some of the VBC requirements. Maria?
Thank you very much, Dr. Fitzgerald, and thank you for taking us through your journey at IU. It's amazing, I think, how philosophically aligned your approach at IU was to what we are doing here at Stellar Health across the country as we're working with primary care practices of all shapes and sizes, and more primary care practices who are in AMCs or affiliated with AMCs, and really helping them optimize the rollout and ongoing improvement of value-based care within their workflow. I think of the principles here on the slide, the tactics and strategies that Stellar deploys to help AMCs meet value-based care requirements, a number of these Dr. Fitzgerald just mentioned, particularly the timely financial rewards. Physicians, and I would also say clinical and clerical staff, are rational economic actors. We all are, and we respond to those things that earn dollars, whether that's dollars for ourselves or dollars for our entities and organizations. And at Stellar, we believe that each person who helps drive that value-based care outcome should be participating in the value that's created. So the Stellar model is designed around the concept of behavioral economics and rewarding individuals for their contribution to better healthcare outcomes for the patient. In order to achieve those outcomes, again, as Dr. Fitzgerald mentioned, the importance of teamwork and collaboration across providers and staff so that everyone's operating at the top of their license. Very practically, Stellar drives engagement with all roles in a clinic, everyone from a front desk receptionist up to a physician, and carves out pieces of the value-based workflow that each of those team members can take on in order to play their part, create greater value for the practice, and then again, earn that incentive payment for the time spent doing that work. How this all works is through the Stellar application, which provides real-time patient information at the point of care. Information that is actionable. Again, I think Dr. Fitzgerald's lesson learned around not boiling the ocean is very important. When a patient comes in for a visit, whether it's an annual visit, a value visit, or even a fee-for-service acute visit for a sore throat, there are value-based actions that can be addressed in that visit, and we encourage our provider partners to take advantage of each touch point with the patient to make every visit a value visit. But we also recognize that you can't give the practice the full list of every single thing that patient needs. It's all about feeding it in an actionable manner to the team members who can best act on that information. Finally, a couple other principles here that we believe in at Stellar are that value-based care work needs to be integrated into the practice's workflow. If you are to bring tools to a practice, simply adding tools and capabilities does not create value. It's the people that create the value, and encouraging those team members to interact with a tool in a way that fits the staffing structure, and the existing resources that that clinic may have. And then finally, it's important, we believe, that value-based care is payer agnostic. The principles of value-based care of providing better health outcomes to the patient, creating a better healthcare experience for the providers, means that no patient should be treated differently because of the insurance card they have in their wallet. So we have established a way for practices to engage in value that allows them to consistently deploy this work across their entire panel, driving outsized results across the entire panel. And we've actually seen this with the health system we were working with in the Northeast. We were working with them on a small percentage of their panel through one Medicare Advantage plan. We recently brought on their MSSP ACO. And with that, not only were the MSSP ACO patients now engaged more proactively, but we actually also saw greater outcomes on the smaller patient panel that had been initially launched. So it's helping create consistency in the practice that will create those outsized results. What are some of those outsized results that we're seeing? At Stellar, we're very focused on driving engagement and helping AMCs engage affiliated networks. We had recently onboarded 80+ practices for an AMC that had seen independents opting out of a value-based care incentive program for a variety of reasons, staffing, resources, et cetera. But by rolling out a program like Stellar across the entire AMC, both their employed and affiliated primary care practices, again, we helped create that consistency that allowed value-based care to be more approachable, even for those independents who had less infrastructure in place to act on value-based care. That then created better outcomes for the entire group, as that group then ultimately improved their shared savings results the year Stellar was implemented. Stellar prioritizes proactive patient outreach. As I mentioned, helping the staff work at the top of their license is one of the areas where we'll engage receptionists and front desk staff to do patient calls, and we'll help stratify that list of patients so that those patients with the greatest need are brought in for visits earlier and more often in the calendar year. Just this year, we've launched with an AMC who over a 6-month period has improved their annual visit completion rate by 7%. We expect that to continue over the last 4 months of the year, and we'll expect to see even greater completion percentage next year as we have more of their practices fully engaged and using the Stellar model to drive workflow. Dr. Fitzgerald hit on the importance of HCC documentation and risk adjustment accuracy as something that directly impacts the bottom line of shared savings earned, and also more accurately represents the illness burden that an AMC is taking on. As we've talked about, AMCs often take on a much higher illness burden, but often aren't documenting it in a way that they can get credit for that risk, whether it's through ACO or health plan programs. We'll provide hands-on education to both physicians and staff, including medical assistants, scribes, and billing and coding specialists to ensure that what happens in that patient visit is appropriately documented on a claim, whether that's coming in through an annual wellness visit, an annual physical, or an acute care visit. Through the engagement information that Stellar is able to collect with our live practices and pairing that with the claims data we receive from our health plan partners, we're able to get very nuanced insights into how physicians and staff are interacting with HCC documentation and what that translates into from a coding and reimbursement standpoint. From there, we're able to tailor specialized training for these practices to help them understand that breadth matters just as much as depth when most accurately documenting HCCs. For example, in a health center we were working with in the Midwest, we helped them identify and give primary care physicians confidence in their ability to address and document HCCs that they discussed with the patient, even if that patient may also be managed for that condition from a specialist. And then finally, the core component of the Stellar model that has proven to drive better outcomes for AMCs is the granular incentive payments, and aligning those incentive payments with the work that the cross-functional team does day in and day out to get these gaps closed. I'll advance a slide here. This slide gives you a graphic of how the Stellar incentive model works. In the status quo, performance is measured in very binary manner, where colonoscopies, for example, are either complete and incomplete. And often practices don't get credit for completing colonoscopies until they've hit a certain threshold that opens or unlocks the gate to shared savings. From a Stellar standpoint, we believe in compensating for work as it's being done. Essentially taking the concept of an RVU in the fee-for-service world and creating what we call the SVU, or the Stellar Value Unit, in the fee-for-value world. In the fee-for-value world, every action should be compensated for to help that practice make the trade-off and prioritize the work that we know will drive better outcomes for the patient, the provider, the health plan. So here you can see the various granular actions, both administrative and clinical, that need to be completed in order for that one colonoscopy screening to be completed. So we recommend compensating throughout the month, and then Stellar will cut a check to the practice each month. And with that check, we receive very positive feedback from the recipients, as you can imagine. Oftentimes it is the front desk staff or the medical assistant or the nurse who now receives $50 to $100 additional a month for the work that they're doing in value-based care. And those dollars become incredibly meaningful to these folks and can actually make the difference in retaining those staff in the practice at a world where healthcare staff are very often tempted by retail roles where they can make a higher hourly wage. We really believe and have seen in practice that sharing those dollars down with the team members doing the work empowers them to take on some of these additional tasks that will create better health outcomes and lead to more affordable care in the long run. And how are our provider partners and our AMC partners reacting to this change in workflow and this revised model? I won't speak to each of these quotes, but you can see here a blend of the principles that Dr. Fitzgerald walked through in practice. By giving these team members access to information at the point of care, helping them stratify their population, get them compensated for doing proactive patient outreach, and ultimately closing the loop when outside care is recommended. Not only are we helping these practices provide better care to their patients, potentially identify conditions that the patient may not even have realized they had or hasn't been treated in a number of years, but we're also making the experience more enjoyable for those physician and staff members who have been asked time and time again, year over year, to take on more work in value-based care. But in order for value-based care to be sustainable and to achieve that ultimate outcome that we're all looking for, we need to help these team members prioritize this work in a way that makes sense for them, both from a workflow standpoint and from an economic standpoint. So I will pause there and open up the conversation for Q&A. I'll leave you with here this one final slide with an overview of the Stellar model. We work with a handful of AMCs across the country, and more are finding that this model resonates with AMCs. And I would love to continue the conversation with those of you who represent AMCs, understand what challenges you've run into as you've implemented and worked on optimizing your value-based programs, and share again more of our lessons learned on the ground working with these team members in their individual clinics. Thank you all very much for attending. It looks like our participation has been fairly stable throughout this entire hour, so we really appreciate that and look forward to the questions that you have for myself and Dr. Fitzgerald.
Okay, yeah, we did have a number of questions come through, and so I'm going to get to as many of these as I can. We have a few minutes, so but if you do have a question, please ask it now. And again, if we don't get to yours, we'll make sure to answer it via email afterwards. So go ahead and contribute what you can. In no particular order, I'm going to start here. How can we position this to get our compensation committee on board?
Well, I can take that one because we wrestled with this over the years. First, as it relates to providers, at one time we had transactional payments, and more recently, it was based on was just a component of their compensation plan, which put some money at risk if they didn't hit goals, but also offered them higher levels that they otherwise would have earned in a typical volume-based thing. And our argument to the comp committee and to our attorneys, who are always so concerned with market-based compensation, was you can't rely just on our views. This participate here requires additional work. It takes longer. You're doing chart reviews. You're identifying individual patients that need to come in, sometimes calling people yourself. It takes extra effort to assure that care is closely coordinated, to interact with care managers and pharmacists to better manage. So we presented that to the comp committee, and they agreed. It takes more work, and this is a direction that if this type of care is the direction that we're going, we need to reward people for the work that will promote organizational or institutional success. And so that's how it was framed. Now, with the office staff, we originally were paying directly to office staff members. And we did that for a couple of years. It was well received. But because we were such a large system and we had many different individuals with the same job title and the same job classification in other areas of the organization, we couldn't pay our office staff one way and not the other. So instead, we took the payments and put them into an office pool, and it funded activities, picnics and Christmas parties and lunches and so forth. And while it didn't go directly in office staff's bank account, they appreciated the reward otherwise.
I agree with that. I think the compensation matters, but first and foremost, the recognition, the immediate recognition for work being done and time spent is incredibly important. As we're rolling Stellar out, we'll do similar approaches where you may start with using the earned incentives to go into a staff fund that staff members can use to apply to go to conferences or other educational events, to invest in things like a standing desk or improved office furniture to make their work life a little bit easier. And then working with those compensation committees to eventually help free the dollars for the team members doing the work.
Great. Good. Well, we've got a number of questions, so I'm going to get through as many as we can, guys. But again, please ask your questions if you got them. Second is there a recommended minimum clinical FTE for a primary care faculty member at an AMC to make success in VBC more likely?
I don't know that there's a lot of science behind this, but if we required a 50% effort of our primary care physicians to have them have a panel of VBC patients. We wanted them to be available at least 4 days a week in the office to address clinical problems. I don't know if that's the right threshold or not, but that's what we used.
Great. Next question here is, does physician education on documentation include Z codes for social determinants of health?
Yes, more and more, that's exactly where we see both our AMC and also our health plan partners going, where social determinants of health are becoming an increasingly important piece of the puzzle in providing care, and also means then it needs to be documented. And as we see things like patient experience become a larger and larger component of health plan reimbursement from CMS, I think that documentation is only going to continue to increase, and the demands of getting that information documented, it will fall back to the primary care practice. And so that's certainly something we and our product team have our eyes on and are very aware of, to again ensure that we're creating that dynamic value-based fee schedule that continues to compensate and educate physicians and their teams on those pieces of the puzzle that are important, not only for better patient outcomes, but again, for financial outcomes as well.
And while today the Medicare risk adjustment process does not include social determinants of health in it, it is quite likely that in the upcoming years, and sooner rather than later, the method of risk adjustment will include social determinants of health, as well as clinical characteristics of a patient.
Agreed.
So emphasizing the importance of educating physicians about its use.
Wonderful. Okay, next question is, has your program implemented any pharmacy services? And if so, where have you placed the focus?
The only pharmacy services that we used were deploying clinical pharmacists in the primary care office to help the docs address polypharmacy and perhaps help with management of conditions such as anticoagulation or diabetes or heart failure, hypertension, and so forth, and which would increase the access or availability of our primary care physicians. Otherwise, we really didn't. I think the group is starting to now in the area of specialty pharmacy and looking for more efficient use of that.
And I'll add, Stellar does have medication management actions built out, and we do work with our practices to address things like brand to generics and moving from a 30-day to a 90-day fill, things like that. And again, trying to align with industry metrics, CMS value-based programs to ensure that anything the physician and the staff are asked to do or asked to manage as it relates to pharmacy is included and compensated for through the Stellar model.
Wonderful. We have time for one more question, unfortunately, because we have some really great questions that came in. And again, please submit your question if you have one. We'll get back to you. But the last question we have time for is, I represent an allied health professional group. We do see incentives in VBC trickling down. Oh, I'm sorry. How do you see incentives in VBC trickling down to non-physician providers?
So, go ahead, Maria.
No, I was going to say that's the crux of our model. And it starts with the social contract. Whenever we're beginning to work with the practice, we ask the practice leadership to make a commitment up front as to what percentage of that monthly check will be shared down to the team members doing the work. And then as we're training those team members on the model, we're able to communicate that to them. So it shows the dedication and commitment of leadership. Then the tool itself gives you the financial value for the work that you're doing. And then each month we create and show reports through the tool so each individual knows what they can expect to see in their take-home pay. We do work very closely with both finance and HR teams at AMCs to roll this out for those practices that do make that commitment to staff. But from my standpoint, it's all about making the commitment and then communicating it and following through on that commitment.
Wonderful. Well, guys, unfortunately, that is all the time. We do, again, have some other great questions that I'd love to hear you guys talk about, but that is all the time we have for today. That said, if this is a topic that you'd like to hear more about, or even a part two, if we could convince these guys to come back, let me know, and we can put that together for you. You can send me an email. But as we close out, I want to thank our speakers, and I think it was a wonderful presentation. And I want to encourage you guys to go visit the Stellar Health Exhibit Hall booth at vbcexhibithall.com. They have a virtual interactive booth there that you can interact with their team, learn more about their services, do a little deeper dive into what they're doing, and there's just a lot of great resources there. Also on vbcexhibithall.com is where the recording for today's session will be housed in our library, and we have a variety of different webinars in there that are housed, but this will be in there as well. Of course, I'm also going to send it to you later on today. And then finally, I wanted to just again thank you all for coming to the presentation today. I know you have a lot vying for your attention these days, and with the holidays coming up and summer ending out. So thank you for spending the afternoon with us. Again, we'd love to hear your feedback. Please reach out. There's the emails of our speakers today is on the slide here. So if you would like to reach out to either of them directly, that's fine, or you can reach out to me. I'm happy to facilitate an introduction as well. So again, thank you so much for coming. I hope you have a wonderful rest of your day. Have a good one.